Welcome dear students, I am Dr. Pratyusha and in this video let us look into the disorders of middle ear. And the first disorder that we are going to see is Acute Suppurative Otitis Media, in short called as ASOM, Acute Suppurative Otitis Media. So, acute suppurative otitis media is defined as an acute inflammation of the periosteal layer of the middle ear cleft by pyogenic organisms. Suppurative means pus causing or purulent. So, this condition is caused by pyogenic organisms. Acute suppurative inflammation of the middle ear cleft. Now, middle ear and middle ear cleft are not exactly the same. Middle ear cleft includes the middle ear cavity proper along with the Eustachian tube, mastoid antrum, editors to the antrum and all those structures. Now, infection from one compartment usually spreads to all other compartments because of a continuous mucosa and absence of any strong barrier between these chambers. So, ASOM is actually inflammation of the entire middle ear cleft by pyogenic organisms. Now, ASOM is usually seen in infants and children because in them the Eustachian tube is short, wide as well as more horizontal. Now, there is a difference in the Eustachian tube anatomy between adults and children. So, children have a more predisposition for acute suppurative otitis media because of their structure of Eustachian tube. And the highest incidence is between the age group of 6 to 24 months, that is up to 2 years of age. So, the disease is more common in infants and children. In the age group of 6 to 24 months. Highest incidence is present. So, now let us look into the routes of infection. How is an infection occurring in the middle ear? First and the most important route is via the Eustachian tube. It is usually a pharyngeal pathology that spreads via the Eustachian tube into the middle ear and causes acute otitis media. Reflux of the nasopharyngeal secretions will result in otitis media. Now, when do these refluxes occur from the nasopharynx? Either while swallowing or while forceful nose blowing or closed nose swallowing. That is why even Valsalva maneuver is contraindicated in a person suffering from some upper respiratory infection, as doing a Valsalva in that situation will propel the secretions from the nasopharynx into the middle ear and cause otitis media. So, Eustachian tube is the most common route. Via the reflux of nasopharyngeal secretions. So, a viral upper respiratory tract infection usually precedes ASOM. Why? Because this upper respiratory tract infection is the one that is traveling via the Eustachian tube and causing otitis media. And after Eustachian tube, there are some other routes which are of less importance, but although they are possible. That is a pre-existing perforation of the tympanic membrane. When there is a perforated tympanic membrane, infections from the external ear can reach the middle ear via that perforation. Any entry of infectious organism into the external auditory canal can directly go into the middle ear and cause otitis media. Another possibility is during an injury. when there is head injury or a fracture of the temporal bone, in such situation also, middle ear infection could occur. And this can also lead to a complication, that is meningitis. And finally, the least possible route is hematogenous route. Now, blood-borne infections of middle ear are very, very rare. Now, let us look into the predisposing factors. What are the predisposing factors? Any condition that leads to an abnormal function of the Eustachian tube are predisposing factors for otitis media. Now, what could they be? Some examples I can give you, such as repeated adenoid hypertrophy and infections in the nasopharynx. Something as simple as repeated attacks of common cold, repeated attacks of upper respiratory tract infection, exanthematous fevers like measles, diphtheria or whooping cough. Let me write down a few of them for you. First and most important is adenoid hypertrophy, because this does not allow the Eustachian tube to function properly. Then, repeated attacks of common cold and other upper respiratory tract infections. Can you think of anything else? Tonsillitis. Tonsillitis affects the movements of soft palate and it does not allow proper opening and closing of the Eustachian tube. Then, recurrent rhinosinusitis. Instrumentation of the nose or nasopharynx. This is an iatrogenic cause. Instrumentation of nose or nasopharynx. We are introducing an infection that will later on spread to the middle ear. Now, why is instrumentation into the nose or nasopharynx done? One common indication is epistaxis. Any nasal allergies, because that will lead to edema of the opening of Eustachian tube. Just like adenoid hypertrophy, any tumor in the nasopharynx will also affect the opening of Eustachian tube. Cleft palate. And also finally, poor immune status of the patient. This is true for any infection. When the organism is highly virulent and the immune status of the patient is poor, it will lead to an infection. So these are some of the predisposing factors. Now, why could there be poor immune status? In a malnourished child, we can see that exposure to some extreme climatic conditions, poor dietary habits, poor lifestyle, all of them will lead to a poor immune status in the patient. Now, another important factor that has to be borne in mind in case of babies, infants and small children is feeding a baby in horizontal position. As such, the Eustachian tube is more horizontal and wider in children. Feeding the baby in a horizontal position will lead to pushing of these fluids into the middle ear, and that has to be avoided. Otherwise, it can act as a predisposing factor for otitis media. Now, let us look into the causative organisms. Causative organisms of ASOM. Most common organisms that are found are Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, And some other organisms that usually cause ASOM are Streptococcus pyogenes, Staphylococcus aureus. Now, generally when we are naming causative organisms, Staph aureus is the first infection that comes to our mind. But in ASOM, it is not the one of the top reasons. The most important organisms are Strep pneumoniae and Haemophilus influenza. And sometimes, rarely, even certain gram-negative bacilli such as Bacillus proteus and Bacillus coli can also cause. And in some cases, the organism is not even isolated. Next, let us look into the pathology and clinical features of ASOM. What exactly is happening and how is the disease progressing? We classically study ASOM under 5 stages. So, let us see all the 5 stages. The first stage is the stage of tubal occlusion. In tubal occlusion, there is edema and hyperemia, redness of the nasopharynx. The nasopharyngeal end of Eustachian tube is occluded, and this will lead to absorption of all the air from middle ear. First, oxygen diffuses into blood, followed by carbon dioxide, and then all the gases slowly diffuse out into the blood, leading to negative pressure inside the middle ear. And this negative pressure of middle ear will lead to retraction of tympanic membrane. So, this is basically what is happening in tubal occlusion. There is nasopharyngeal pathology, that is leading to closure of Eustachian tube, and this leads to negative pressure in the middle ear. Negative pressure in middle ear will lead to tympanic membrane retraction. Now, the symptoms that are present in this stage are the clinical features. There is mild amount of ear pain and ear fullness is seen. Ear fullness and ear pain. That is quite mild and bearable. There is no fever even at this stage, and mild hearing loss is present. And when we examine the tympanic membrane, what we find is a retracted tympanic membrane. Retracted tympanic membrane is found. Signs of retracted tympanic membrane we have already studied in the disorders of tympanic membrane. That is, there is relative shortening of the handle of malleus. The entire membrane appears dull. Cone of light is distorted, and there is prominence of the lateral process of malleus. All these features are seen with a retracted tympanic membrane. I can show you a picture of retracted tympanic membrane. So, this is how a retracted tympanic membrane would look like. There is prominence of the lateral process, the cone of light is distorted, and all the structures inside have become more visible and conspicuous. This is the first stage of tubal occlusion. Now, let us move on to the second stage, and that is the stage of pre-suppuration. Now, when the Eustachian tube is closed for a prolonged period, this facilitates invasion of pyogenic organisms into the middle ear. And this invasion will cause mucosal hyperemia. So, there is invasion of pyogenic organisms and this results in mucosal hyperemia. This is the main feature of stage 2, that is stage of pre-suppuration, and the clinical features that we observe at this stage are: there is throbbing ear pain now. In the stage of tubal occlusion, the pain was very much mild and bearable, but here there is throbbing ear pain. Sometimes even the patient cannot sleep. They wake up in the middle of the night because of unbearable pain. Plus, there is high fever. There was no fever in tubal occlusion, but here there is high fever is present. Plus, there is some bubbling sound in the ear. In the earlier stage, there was only ear fullness, but now a bubbling sound is present. Plus, also there is hearing loss. Now, hearing loss is much more than the previous stage. But hearing loss is not the complaint with which the patient presents to you, because the hearing loss is not given enough attention because of the severe pain. The patient is not bothered about the hearing loss at this stage. And upon examination, what we find is that the tympanic membrane is now congested and it is bulging out with a cartwheel appearance. This is very, very important. The tympanic membrane is bulging. Why? By now there is fluid that is present in the middle ear, so that is pushing the tympanic membrane. The pars tensa part especially is bulging out, plus there is cartwheel appearance. This cartwheel appearance is very important. Along with the cartwheel appearance, you will see a leash of blood vessels at the periphery or at the handle of malleus. And then we see that there is loss of light reflex. The cone of light is not just distorted, it is completely absent. And later on, the tympanic membrane completely bulges out. It gets uniformly congested. It becomes red. Tympanic membrane is congested. Initially, a leash of blood vessels was present only at the periphery, and in the later stages, the entire tympanic membrane becomes congested. And also, there is hearing loss when we do tuning fork tests. This is the stage of pre-suppuration, and let me show a picture of how the tympanic membrane looks like in this stage. So what you can see here is a leash of blood vessel at the periphery plus at the handle of malleus. Plus this is the cartwheel appearance with the spokes. I hope you are able to appreciate. Let me remove the annotations so that you can clearly observe. So there is cartwheel shaped appearance plus leash of blood vessels, which are two most important features of pre-suppuration. Coming to the third stage of ASOM, it is suppuration. Pre-suppuration followed by suppuration. Here there is formation of frank pus that is seen in the middle ear and also in the mastoid air cells. Frank pus is seen. And the tympanic membrane continues to bulge. So the clinical features seen at this stage are: already the patient was having excruciating pain and fever in the second stage itself. So here also that continues. There is excruciating ear pain. Now the hearing loss becomes more here. Increased deafness. And also there are constitutional symptoms because of fever, such as vomitings, malaise, body pains, and all of them are seen. Sometimes even as severe as convulsions could be present. And upon examination, what we find is the tympanic membrane is now completely red and it is bulging out. First stage, it was retracted and then slowly it started to bulge and now it is completely bulging out. Now it looks like it's almost about to rupture. It is under high tension. And the handle of malleus is engulfed by the swollen tympanic membrane. You cannot even appreciate the handle of malleus. All the landmarks of tympanic membrane have disappeared now. So, it is about to rupture. Handle of malleus is engulfed by the swollen tympanic membrane. And if we examine the mastoid area, there is tenderness that is present. Because now it is not just in the middle ear, the infection has spread to the mastoid area also, and mastoid area tenderness is felt because of mastoiditis. And if we take an X-ray at this stage, clouding of air cells in the mastoid can be observed. If you can see this picture, I hope this picture provides a clear understanding. You can see that the tympanic membrane is completely bulged out and it is swollen. You can no longer see the handle of malleus or any other anatomical landmark there. Plus, there is complete congestion and redness of the entire tympanic membrane. The cartwheel appearance of the previous stage is lost. Now, let us move on to the fourth stage of ASOM, and that is the stage of resolution. In the stage of resolution, what happens is the tympanic membrane will rupture out. There was impending rupture in the stage of suppuration itself, and here the tympanic membrane ruptures out because of the pressure and it will result in otorrhea. All the fluid will start coming out into the external auditory canal via the perforated tympanic membrane. So there is rupture of tympanic membrane followed by otorrhea, and then all the symptoms will slowly start to subside. Now, the patient usually tells you that after fluid started coming out, they felt a relief in pain. All the symptoms will slowly subside and even the inflammatory process will start to resolve. So, the clinical features that are observed at this stage are, there is resolution of symptoms. But most importantly, you will see a discharge from the ear. And how is the discharge? It is either serosanguinous or sometimes blood-stained. Initially, it is serosanguinous or blood-stained, and later it becomes mucopurulent. The ear pain and fever will subside. There was excruciating pain and high fever in the stage of suppuration. Here they both will subside. And on examination, what we find is that the external auditory canal is filled with these secretions, and it is hard to examine the tympanic membrane also. External auditory canal filled with secretions. Here you observe something called as lighthouse sign. What is lighthouse sign? It's also called as pulsatile otorrhea. Now, the secretions that are coming out of the perforated tympanic membrane show some pulsatile features. It appears like a lighthouse. I hope you know what a lighthouse is. In oceans and seas, some tall towers or buildings are constructed with a flashing light on top of them. They are meant to guide the ship captains about a sense of direction, and they also are placed when there is some danger signal. So that is a lighthouse. And this secretion that is coming out of the ear looks like a lighthouse that is flashing, and so this is called as lighthouse sign. Now every bout of pus that is coming out is in synchrony. Repeat. Now every bout of pus that is coming out is in sync with the heartbeat, with the arterial dilatation of the heartbeat, and that is why it appears pulsatile. So it's also called as pulsatile otorrhea. And if you clean these secretions and examine the tympanic membrane, what you find is a perforation. Perforation of the tympanic membrane is seen, and it is usually in the antero-inferior quadrant. It's usually in the antero-inferior quadrant. Please look into this picture. This is a picture of perforated tympanic membrane. You can very clearly appreciate the perforation. That's in the antero-inferior quadrant. It's slightly extending into the antero-superior quadrant also. So through this perforation, all the secretions come out and the patient finds a relief. There is yet another stage, and that is the fifth stage, called as stage of complication. In majority of the patients, ASOM is a self-limiting condition and it responds well to treatment and ends with resolution. But sometimes when the virulence of the organism is very high and the resistance of the patient is very poor, or there is no proper treatment, it could lead to complications, and that is the infection spreads beyond the middle ear cleft and fails to resolve. And complications usually occur in the second week of the disease. Now, the constitutional signs and symptoms of infections which were resolving in stage 4 will begin to reappear. That is, the patient will again have pain, will again have fever. So, what are some of the complications that occur? Let us see. Mastoiditis can occur, which is, I can say, most common. A subperiosteal abscess can occur. Meningitis. Facial nerve paralysis. Extradural abscess. And a brain abscess or a cerebral abscess. Lateral sinus thrombophlebitis. These are some of the complications that can occur after ASOM, and infants are at a greater risk because meningitis and acute otitis media usually coexist with one another. So, these complications, please remember them, because we will again look at these complications in chronic otitis media also, and then let us discuss about all of them in detail. Now, this is the staging of this disease. First, there is tubal occlusion, followed by pre-suppuration, suppuration, resolution, and complications that can occur or may not occur. Now, what you have to remember is this is the natural course of the disease that occurs when we do not intervene. But when antibiotic therapy is given at any stage, it will reverse and not progress further. So, at a stage of pre-suppuration itself, if you identify the patient and give him antibiotics and treat the condition, he might not progress up to perforation of the tympanic membrane and resolution also. There itself, at the stage of pre-suppuration itself, the condition will resolve. So, this is the natural progression of the disease without any treatment. I hope the clinical features and pathophysiology of ASOM is clear to all of you. Next, let us look into the diagnosis of this condition. Now, the diagnosis of ASOM is more or less clinical. It is very easy to identify a patient with ASOM. It's usually a child that's complaining of ear pain, fever, and there are few other constitutional symptoms like malaise and headache. And also, if we examine the ear, depending upon the stage, we find various findings such as either the tympanic membrane could be retracted or it could be bulging out, or finally the patient may present you after it has perforated also. So the diagnosis is more or less clinical. What we have to do is a tuning fork test to identify the hearing loss. In case you do a CT of the temporal bone, you will find some mastoiditis changes. It's usually indicated only when there is refractory mastoiditis. Only then we go for a CT of the temporal bone, and there we find clouding of the mastoid air cells. So the diagnosis is clinical. Imaging is done only in complications. Imaging is done only if there are complications. What we also have to do is collect the fluid, the secretion that is coming out of the ear in case the patient presents to you at that stage, and send that for culture and sensitivity so that will give us a clue about the type of organism involved and its antibiotic susceptibility. So culture and sensitivity of the secretion have to be done. Now let us see the treatment of acute suppurative otitis media. We can divide cases of ASOM into those with complications and those without complications because there is some slight difference in treatment between the two. So ASOM without complications and with complications. Now it is a simple case without complications. We go for first line antibiotics. Because this is an infectious condition, antibiotics are our first line treatment. And first line antibiotics are usually amoxicillin or co-amoxiclav. Even before obtaining the results of culture and sensitivity, we begin with the antibiotics. Now after giving antibiotics, there are two situations that are possible. One is resolution of symptoms, which means your treatment has worked and the patient is feeling better. You will follow up the patient after 4 to 6 weeks to see if there are any complications. If there are no complications, that is the end of the story. In follow-up, what you're basically looking for is if there is any middle ear effusion. Because middle ear effusion indicates that the tube has again occluded and the patient is in some vicious cycle. So if middle ear effusion is absent, that is the end of the story. There is no further follow-up that is required. So this is the best scenario that is possible. The patient has come up to you with ASOM, you have clinically diagnosed the condition, you have given first-line antibiotics, your therapy worked, there is resolution of symptoms, and after 4 to 6 weeks when you examine the patient, there is no middle ear effusion, and there this line will end. In your follow-up, if middle ear effusion is present, you have to treat that effusion. How will you treat the effusion? You will find out the cause for middle ear effusion. Is there any nasopharyngeal pathology? Are there adenoid hypertrophy or are there tonsillitis present or any other tumor present in the nasopharynx? You have to find out why middle ear effusion is occurring and treat that condition. This is about resolution of symptoms. if there is no resolution of symptoms even after giving antibiotics. If the symptoms do not subside, no resolution even after 2 to 3 days. Generally, in 2 to 3 days of antibiotic therapy, the patient will find relief. If there is no resolution, then what will we do? We will go for second line of antibiotics. Maybe the organism is not susceptible to first line antibiotics, so we go for second line antibiotics such as a cephalosporin or a combination of amoxicillin and clavulanic acid. After giving second line of antibiotics, again 2 scenarios are possible. The symptoms can resolve, resolution of symptoms, or no resolution. Even after giving second line antibiotics, it's possible that there is no resolution of symptoms. If there is resolution of symptoms, you will follow this pathway. That is, you will follow up the patient after 4 to 6 weeks and check for middle ear effusion and decide accordingly. That is again the end of the story. But if there is no resolution, then what to do? We have to go for a procedure known as tympanocentesis. Tympanocentesis. Now, I am assuming the patient has come to you even before the tympanic membrane has perforated. Because if the tympanic membrane perforates and the pus has come out, it will resolve by its own. It's a self-resolving condition. So, this entire treatment plan is if the patient has approached you at the stage of pre-suppuration or suppuration. At the stage of tubal occlusion, they usually don't come because the pain is very much tolerable and there's no fever and all. Usually, the patient comes at the stage of pre-suppuration or suppuration. So, at that stage, even if your second line antibiotics are not working, then we do something called as tympanocentesis. What is tympanocentesis? With a small needle, we puncture the tympanic membrane, go into the middle ear and drain the pus and the fluid that is present with the help of a syringe. And those secretions we send for culture and sensitivity. And based on that report, we go for antibiotic therapy. So, with tympanocentesis itself, the patient experiences relief after the pus is all drained, plus the antibiotic therapy will give him further relief. So, what we do is, we follow up the patient after 4 to 6 weeks. This is usually done when there are no complications. First line antibiotics, if that fails, second line antibiotics, if that also fails, then we go for tympanocentesis. With tympanocentesis, usually there is success. But sometimes this can also fail. And let us see what happens then. That matches with this chart, that is when there are complications. Now, how will you identify the patient is having complications? The patient will not come and tell you, I am a complicated case. There are some age groups where you consider it to be a complicated condition, such as if it's a newborn, a neonate, or an immunosuppressant person. The patient is a known case of uncontrolled diabetes or undergoing immunosuppressive therapy post-transplant, or is a known case of AIDS. All of them are immunosuppressed. Or if the patient already presented to you with complications such as meningitis, any extradural, subperiosteal or cerebral abscess, or facial nerve paralysis, or labyrinthitis. At the time of presentation itself, the patient is having these complications. or if it is a newborn or an immunosuppressed individual, or you can see that toxic or septic look on that patient, then it is a case of complication. And what do we do then? Directly we go for tympanocentesis. We do not waste time giving antibiotics and see if they work or not. We immediately go for tympanocentesis. Check that secretion for, send that secretion for culture and sensitivity, and along with tympanocentesis, we also give antibiotics. So this is how a case of ASOM is managed. This is more or less only about antibiotics, but there are also some other drugs that are given in case of ASOM, and let me talk about them. So first is antibiotics, and you have already studied first line antibiotics such as amoxicillin and second line antibiotics such as cephalosporin. Cephalosporins, first line antibiotic such as amoxicillin and second line antibiotics such as cephalosporins are used. And they are usually given by intramuscular route, and a course of 10 to 14 days, 10 days to 2 weeks is prescribed. After antibiotics, using decongestants is also very important. Decongestants will reduce the edema that is present at the nasopharyngeal end. Now we can use topical decongestants or oral decongestants also. In topical decongestants, they are used as nasal drops. What we usually use is oxymetazoline or xylometazoline. Oxymetazoline or xylometazoline. They will relieve the Eustachian tube edema and promote ventilation of middle ear. But in certain very small children, it is difficult to administer nasal drops. So then we can use oral nasal decongestants such as pseudoephedrine. Pseudoephedrine is used, or phenylephrine hydrochloride can also be used. Phenylephrine hydrochloride along with antihistamines. Then analgesics and antipyretics are also important parts of treatment because the patient is suffering from pain as well as fever. The most common analgesic and antipyretic that we use is paracetamol. This will help reduce the pain as well as fever. Plus, some local care has to be taken, such as cleaning the ear. Whenever secretions are coming out, the ear discharge has to be cleaned. Prevention of entry of water into the ear is very, very important, as that will not help to control the infection, plus it aggravates the infection. And not putting foreign substances into the ear is also very, very important. So local care of the ear and even putting some dry local heat is helpful to relieve the pain. Apart from all that, there is surgical treatment. In surgical treatment, we have already studied about tympanocentesis that is done. When there is no resolution even with second line antibiotics, and also in complicated cases, we do tympanocentesis. And after tympanocentesis, there is another procedure that can be done, and that is myringotomy. What is myringotomy? A small incision is given on the tympanic membrane and all the middle ear fluids are evacuated. This is usually done after tympanocentesis. If there is no relief with tympanocentesis, we go for myringotomy. Why we do myringotomy is, after giving an incision and draining out all that fluid, we place a ventilating tube called as grommet. A grommet is inserted at the site of incision, and this grommet will help to keep the middle ear ventilated. Plus, if there is again refilling of secretions, through the grommet we can drain those secretions out. That is myringotomy. Usually, it might not be necessary because ASOM is a self-resolving condition. But ultimately, it might need to be done sometimes when the medical treatment doesn't work and the secretions are very, very heavy. So this is about ASOM. You have to remember that it spreads via Eustachian tube, that is the most common route. And then clinical features are divided into 5 stages. The stage of tubal occlusion, pre-suppuration, suppuration, resolution or complication. It's not usually resolution followed by complication. Sometimes it can directly go into complication also. And then in diagnosis, it's usually clinical diagnosis. And in management, it is about medical management first with antibiotics, nasal decongestants, and also analgesics and antipyretics. And sometimes surgical management with tympanocentesis and myringotomy might be required. In antibiotics, it is divided into with complications and without complications. If it is a case of complications, we have to directly go for tympanocentesis along with antibiotics. If there are no complications, we give first line of antibiotics and follow up the patient after 4 to 6 weeks. If the first line antibiotics do not work, then we go for second line antibiotics and see if it resolves. If it resolves, follow up the patient after 4 to 6 weeks. If it does not resolve, go for tympanocentesis. So this is about acute suppurative otitis media. I hope all of you have understood. Okay. Thank you very much and have a nice day.